My name is Caroline Lozer. I'm with the Lewin Group. Welcome to the webinar, Supporting Older Adults with Substance Use Disorders. This is the second session of our 2018 Geriatric Competent Care webinar series. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded, and a video replay and a copy of today's slides will be available at www.resourcesforintegratedcare.com. The audio portion of the presentation will automatically stream through your computer. Phone lines for this presentation are also available, and to access that number, you can click the black phone widget at the bottom of your screen. Continuing medical education and continuing education credits are available at no additional cost to participants. AGS is accredited by ACCME to provide continuing medical education for physicians and by NSAW to provide continuing education for social workers. CMS is also accredited by IACET to issue CEUs. We strongly encourage everyone to check with your specific regulatory boards or other agencies to confirm that courses taken from these accrediting bodies will be accepted by that entity. You'll see on this slide that we've laid out the various continuing education credit options. If you are a social worker, you could obtain continuing education credit through NSAW if you complete the pre-test at the beginning of the webinar and complete the post-test. If you are a physician, you could obtain CMEs through AGS if you complete the pre-test at the beginning of the webinar and complete the post-test. CMS is also offering CEUs for those individuals looking to obtain credit for attending this webinar. In order to obtain those credits, you must complete the post-test through CMS's Learning Management System. And additional guidance about obtaining credits and accessing the links to the pre-test and post-test can be found within the Continuing Education Credit Guide in the resource list on the left side of your screen, or you can visit the Resources for Integrated Care website. This webinar is supported through the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar series. To learn more about current efforts and resources, please visit our website, or you can follow us on Twitter for more details. Our Twitter handle is @integrate_care. So at this time, I'd like to introduce our moderator. Carol Regan is a Senior Advisor to Community Catalyst Center for Consumer Engagement in Health Innovation and has over 30 years of experience with national and state-based public policy and advocacy organizations. Carol?
Thanks, Caroline, and welcome, everyone. We are so pleased to be introducing this really important and timely webinar. Community Catalyst has been working with the Lewin Group and the Medicare and Medicaid Coordination Office and the American Geriatric Society now for many years on developing a series of educational webinars on geriatric competent care. This is part of our commitment to work across the country to ensure quality care for dually eligible Medicare and Medicaid beneficiaries enrolled in the Financial Alignment Initiative and demonstrations. So today's webinar has 4 really great speakers who will cover a number of topics. Let me start by introducing the faculty, who you can see in front of you. So we'll start with Dr. David Oslin, who is a professor of psychiatry at the Philadelphia Veterans Affairs Medical Center and the University of Pennsylvania Medical Center. He's the director of the Mental Illness Research, Education, and Clinical Center and the chief of behavioral health at Philadelphia Veterans Medical Center. In addition to both organizations support research on comorbidity and integrated care, respectively. He's the author of over 75 research publications and 30 chapters, books, or editorials. His research portfolio includes studies aimed at improving access to behavioral health intervention care, improving treatment outcomes for addictive disorders, and the study of pharmacogenetics. Specific projects have included an adaptive treatment study of naltrexone and to develop strategies and for maintenance treatment and non-response to treatment. Additionally, Dr. Oslin continues to research on implementation and dissemination of evidence-based practices for integrating primary and mental health care. Our next speaker after that will be Dr. Jessica Gregg, who received her undergraduate degree from Stanford, her medical degree from the University of New Mexico, and her doctorate in medical anthropology from Emory. She's board certified in internal medicine and addiction medicine and is a practicing physician with IMPACT, which is the Oregon Health Services University's Addiction Medicine Consult Service. She's also the medical director for OHSU's Addiction Medicine Clinic and associate program director for the Addiction Medicine Fellowship. Her previous work has included work on social medicine curriculum, which places OHSU internal medicine residents, physicians in safety net clinics. She served as a medical director for substance use disorder services and an agency that serves adults impacted by homelessness, poverty, and addictions, and serving as the medical director of the Health Professional Services Program, which is Oregon's statewide confidential monitoring program for health professionals. And she's also published widely on addiction and the current opioid crisis. Then I'll turn it over to Anne Giazzoni, who is a licensed social worker and a supervisor in case management at the University of Pittsburgh Medical Center, UPMC Health Plan, and a combined clinical and management backgrounds. She oversees the case management process for the Rapid Emergency Department Outreach Pilot, which is a program that ensures case management intervention for within 24 hours of an emergency department visit for an overdose. In her work, Anne manages complex, co-occurring medical, behavioral health, and substance use case management programs for high-risk populations. Her focus is on providing person-centered integrated care for people needing assistance navigating physical and behavioral health systems. Anne has got her MSW degree, Master's Social Work degree from the University of Pittsburgh, and her Master's of Business Administration from Point Park University in Pittsburgh. So you can see we have an incredible list of faculty. And then finally, I welcome Carol Prudhomme, who is a consumer from Rhode Island, who will share her recovery story. So there's our introductions, and let's go to the next slide, where we want to know a little bit more about you all who are on this webinar. So we're going to start with a couple of really quick polls. So this poll is, which of the following best describes your professional area? And you may overlap, but pick your primary one. Again, a couple more seconds. Please fill that in. Great. And now let's go to the results. Oh, great. Okay, so we see that a little over a third are from social work, many in the clinical practices, and some administration and advocacy. Thank you. So next poll. So how would you describe your primary role? Again, your primary role. You may overlap with a number of these, but how would you describe yourself in any of these particular roles? A couple more seconds to fill that in. Okay, great. Let's see the results of this one. Oh, great. Okay, so we have a number of administrators and clinicians, educators. We're not adding up to 100 here, and then consumer advocates. Terrific. Okay, and we have one last poll. Please share with us the setting in which you work, your primary work setting. Okay, we take a few more seconds to fill that in. It's really helpful for us to know a little bit more about you. Okay, thanks very much. And the last poll results. Great. Okay, so wonderful. We have a number of people with a managed care organization, some long-term and ambulatory care settings, and a number of community-based organizations. Terrific. Okay, so next slide. So just want to quickly share with you, and you can read these, the learning objectives for this webinar. And we hope that, through this you'll learn a lot about the types of substance use disorders, the epidemiology and the magnitude of this problem among older adults, the benefits and risks of substance use and how it could lead to abuse, define the association between substance use disorder and comorbid mental health issues, and then looking at various treatment options and the need for care coordination. Great. The next slide. And then this is what we're going to try to cover here. We've gone through the polls. We're going to start with talking about alcohol use, turn it over to opioid use, and then talk about how do we support older adults and caregivers and their families struggling with substance use disorders. We'll then close up with a consumer perspective, and then really look forward to the half an hour of questions and answers at the end so we can answer some of your questions. And then we have an evaluation at the end. So thanks so much. And now let me turn it over to Dr. Osland.
Great, thank you, and thanks for all those on the webinar today. It's really exciting to talk about this topic. I've had sort of a lifelong passion of working in this area, so if we could just go to the next slide. So I wanted to start by just talking about how substance use is a little different in older adults, and this is kind of a compilation of the literature and some of my thoughts about it, but when we see people in their 60s and 70s who have a substance use disorder, there's a number of things that we need to think about clinically that are just different. From a health perspective, older adults are clearly more likely to be on medications. And so the issue of polypharmacy as well as interactions with alcohol with any of a number of medications is a really important piece. Alcohol has the most drug-drug interactions of any medication we use, so it just interferes in a number of ways with a lot of the treatment we do. There's sort of limited time to address substance issues in a lot of settings. The average primary care provider spends something on the order of about 90 seconds evaluating mental health disorders in primary care setting of their 10 minutes that they have. And there are just different biological susceptibilities. It takes less alcohol to have more impairment in older adults, and there's a number of biologic reasons for that we don't have time to go into today. But in terms of presentation, pain is a very strong correlate to substance use in older adults, so managing people's pain, either arthritic pain or other musculoskeletal pain, is an issue that is a feature in managing patients. Cognitive impairment is something that has to be managed and dealt with. I'll show a slide later that group therapy has to be really thought of carefully in an older adult. Somebody with very mild cognitive impairment may not be able to really participate in group the way it's intended to. They may get some of the social aspects out of it, but may not cognitively process much of the information. And there's just a number of issues that happen as we get older. We have less structure to our day because we may not have family duties or jobs to do, and have poor health habits. There's anxiety and depression, and suicide is clearly a higher prevalence rate in older adults. So all of those are important in terms of ascertainment and thinking about older adults. And an important issue for me in taking care of older adults is really thinking about generativity or purpose. This is often a struggle for many older adults in terms of what are they doing with their life as they age. And it's just an important piece to assess and think about. So next slide. In terms of dually eligible patients, there's some more unique stuff. Basically, dually eligible beneficiaries are sicker and have more sort of negative health habits, if you will. And I think everybody probably realizes that. And it's just a more vulnerable population. So next slide. So older adults, so this is to just kind of frame us a little bit. I realize that we're going to have a focus on opiates today. Alcohol really, tobacco really still predominates as the substance that is most frequently used in older adults. We don't have a lot of older adult-specific smoking campaigns, but older adults do benefit from tobacco cessation, and because they've been smoking a number of years, the prevalence rate is still actually fairly high. Alcohol then is the next most common, more common than prescription medicines. The range varies for all of these substances depending on the site you're in, depending on your population frame of reference, so to speak. So, higher rates in an ER, lower rates if you go to a community event of some sort and just have normal healthy folks, if you will. But any setting that's a healthcare setting, these rates are actually going to be higher. Psychoactive prescription drug misuse, about 2 to 4%, and the illicit substances in terms of use disorders are still actually pretty uncommon. But kind of a special note about marijuana, we actually don't know a lot about the prevalence rate of marijuana use in 2018 among older adults compared to what it was before a lot of legalization. So there's not real active or contemporary data there. Next slide. So comorbidities, so the same comorbidities exist in older adults that do in younger adults, but there's some caveats here. Cognitive impairment clearly is one of those caveats in the middle here, and suicide is clearly one of those things that we take special note of in older adults. Suicide rates are most elevated in older adults, particularly white men. That still is the case. An older adult that has an alcohol use disorder, whether that's mild, moderate, or severe alcohol use disorder, has about 3 times greater likelihood to have a comorbid other mental health disorder. So, it's just so important to assess and include in the treatment planning the assessment of comorbidities. One caveat here for depression is that, two caveats. One is that we've done a lot of work, and if people really want their depression to get better, or their PTSD for that matter, they need to be abstinent. There's a pretty direct relationship to lack of abstinence and poor outcomes for depression. Now, the other caveat is that there's a strong belief among a lot of providers that if you treat depression or treat the comorbidity, that the substance use will decline. And there's actually almost zero literature for that. You really have to treat both problems. And it's in some ways more important to treat the substance use disorder because the chances of the other mental health disorder getting better are almost zero if you don't treat the substance use disorder. And so clinicians often get this a little backwards. We see a lot of patients on antidepressants with no treatment of their alcohol use disorder or other substance use disorder. So that's a really important factor. Treat the substance use is the punchline. Next slide. So this is just an interesting study that we did asking people who were not actively in treatment, who clearly had alcohol use disorder problems, most of them moderate to severe alcohol use disorder. And while almost all of them said that they needed to cut down and they recognized that drinking was a problem for them, a lot of them had really misgivings about going to an outpatient treatment program, not perceiving that they need treatment in a formal treatment program. And this really begs the question of how do we take treatment to patients that don't see addiction treatment programs as, and we'll come back to this, as something that's viable for them. And you'll see there's a smattering of other reasons. I think it's important to realize that patients have some anxieties about coming to formal treatment programs, and we really need to think about how to utilize. I saw there was a number of AAAs on the call, how to utilize services that could be delivered at AAAs or primary care settings or other settings. Next slide. What are we looking for in a patient? So again, it sort of depends on the setting. But in general, we want to know about drinking at any level. particularly for treating them for other health problems. So people that are drinking more than about one standard drink per day, or who drink more drinks on given days. So we call that binge drinking, but some of my patients binge drink every day. So it doesn't mean cyclical drinking. It just means drinking 4 or more on a given day. For older adults, and the third bullet's huge. There's a lot of medications that are impacted even by the glass of wine at night, and fairly negatively impacted. Coumadin is a great example that you just can't drink on it. It doesn't mean that you have an alcohol use problem. You just can't. You should not combine alcohol and Coumadin. We also, in addition to looking for drinking and the related and issues related to just drinking, which could mean moderate drinking as above, we look for people that have clear-cut addiction. And to me, that means people that have issues of control, issues of craving, or impairments in some form of their aspect of their life. So next slide. This is just to remind us of what a standard drink is, and you can read that on your own there. I used to have a mustache, but that is not a picture of me. Next slide. This slide just gives you sort of a quick pocket card of what a standard drink is. When I teach residents, I often tell them, or we have a little discussion about writing in the chart that the patient drinks a 6-pack. After we do the exercise, we do the math about what a 6-pack could be. And a 6-pack can really actually be anywhere from about 4 standard drinks to about 15 standard drinks, depending on the size of the can of beer. So writing a 6-pack, the punchline is that that's not very helpful to your colleagues or the patient. All right, next slide. This is a quick screener that you can use pretty much anywhere. It's been validated in older adults, younger adults, men, women, whoever. Probably, I don't know about kids, but so it's 3 questions. It's very simple to use. It's a self-assessment. It can be done over the phone. It can be done in the waiting rooms. So the next slide talks about the scoring. It's scored from 0 to 12. A positive score, meaning positive here means somebody that you want to have a discussion with around their drinking. It does not mean they need an addiction treatment program. Is a 3 or a 2 for women. And somewhere, the higher the score, the more likely they are going to need more formal treatment. So that just the higher the score, the more severe the drinking is. Next slide. Talk a little bit about primary care approaches. So the reality for us in the gerontology area is that most patients go to see primary care, but they don't always go to see mental health. There are validated methods of treating patients or giving patients an intervention in primary care. Brief advice, if done properly, is a very valid modality. It takes some training to do. Referral management relates to the idea that what is said in primary care actually so much dictates whether a patient will come see me as a psychiatrist. And there's ways to do that and to be successful at it and to counsel people. And we've been able to do pharmacotherapy for alcohol use disorders in primary care very successfully. The thing for everybody on the phone to remember is, like depression care, substance abuse care can be delivered in a quality way in primary care. And in fact, it's the place that most patients are actually seen. So thinking about how to deliver appropriate services there is something that I'm fairly passionate about. Next slide. Go to the next slide. Or maybe not. I'll do the next slide. This was actually a trial we did of of delivering behavioral health care into a primary care setting using care managers, mostly nurses or social workers or psychologists. The step care approach, identifying people with mild to moderate disease without a lot of comorbidities, treating them in primary care with an emphasis on measurement-based care, providing decision support, emphasizing self-management, and having visits over not having visits, and that's really what the telephone comment relates to. So if patients aren't able to come for a visit or on vacation, you can still do a visit. You can do it over the telephone. Patients love it, particularly older patients, and it's quite effective. We've done some research in this area and shown that this model is actually more effective than sending people to specialty care because more people engage in the model. It really has to do with being able to engage patients where they are and where they want to get treated. Next slide. Thank you. This was a study we did of older adults in terms of thinking about peer support groups, AA mostly, and it just shows that for some older adults it's a little harder to attend that traditional mode of treatment. So they're a little less likely to attend AA, a little less likely to get a sponsor, a little less likely to provide aftercare. So this is after going through a residential treatment program. This is actually the Hazel and Betty Ford program. So they really were indoctrinated, if you will, into the model of peer support, but still struggled. I think, there's a lot of issues there. Transportation, people not wanting to be in groups, people having a little bit of cognitive impairment, not being able to get much out of group. It just all needs to be part of the assessment and not something that is an automatic. All right, next slide. This is just a plug that you can do pharmacotherapy in older adults. There's 4 medications, 3 that are FDA approved and 1 that is used a lot but not FDA approved. My 2 go-tos are naltrexone and topiramate on this list. I use very little antabuse and very little acamprosate. Acamprosate's a 3-time-a-day medication, and then patients are already taking a lot of meds. That's not a friendly thing to add on to. So this is just an option. There's not a lot of difference in using these drugs or medications in older adults, and they're very effective. Next slide. So this is just an example of a primary care patient, kind of a typical patient, just to give you a flavor of sort of how this might work in a primary care setting. It could apply to a AAA or other settings as well. So this is a 59-year-old guy with arthritis, diabetes, and hypertension who says to his primary care doctor he's having trouble sleeping and he's missed work a couple of times. And he's gotten into some increasingly arguments with his wife. And he doesn't raise alcohol as an issue. The primary care visit does, in this setting, automatically screens people. He had a PHQ-2 and an Audit C score. The Audit C was a 9, which is relatively high. And he was in a rush, so he wouldn't stay and talk to anybody. But in this particular practice, is a real practice, the nurse reaches out to him and talks to him on the phone. So next slide. The behavioral health provider, the nurse or the social worker, looks over the chart, calls the patient, talks about treatment options, talks about the Audit C score. He agrees to cut down initially. They have a couple phone calls. The behavioral health provider has a supervising psychiatrist that they go to. Because the patient struggled a little bit, they actually talked about naltrexone. The patient ended up being willing to do that, and you do that continuing follow-up. But in this case, the psychiatrist does not prescribe the medication. What happens is the behavioral health provider, the social worker, goes back to the primary care doctor and makes the recommendation, and it's up to the primary care doctor to agree with that or not, and to start the medication. Often with the support, the provider is quite comfortable doing that. This patient did quite well, as a lot of them do. Next slide. So I guess I covered a lot of this. So there's a couple more visits, and there's education. As part of the plan, there's behavioral activation in terms of trying to get him to do some exercise, to step down his alcohol use, and actually engage family. That's a big one, trying to get them to talk to their family. And he does that, and he actually gets a lot better. So that's just a flavor of how this might work in another setting, and a really fast introduction to alcohol use disorders in older adults. And I'm pleased now to introduce Dr. Gregg, who's going to move us through opiate use disorders.
Thank you. That was terrific. So let's just jump right in. I'm going to talk about opioid use disorder among older adults. Next slide. As I'm sure you're all aware, the United States is in the midst of an opioid crisis. The opioids led to more than 42,000 deaths in 2016, and 40% of all opioid overdose deaths involve prescription opioids. In fact, drug overdose is now the leading cause of death for Americans under 50 years of age. So what about Americans over 50? How is the crisis affecting them? Next slide. They haven't escaped. Opioid misuse among adults age 50 and older in 2014 was higher than all years between 2002 and 2011. And the population of older adults who misuse opioids is projected to double from 2004 to 2020, from 1.2% to 2.4%, based on current trends and the increase in the older adult population. I think sometimes older adults are ignored in this crisis because across age groups, in 2014, adults age 50 or older were the least likely to misuse opioids in the past year, while young adults age 18 to 25 were the most likely. But even though the proportion of older adults who misuse opioids is relatively small compared to young adults, the National Survey on Drug Use and Health and the data above suggests that opioid misuse is increasing significantly among older adults, and they are suffering the consequences. Next slide. So why is this happening? Why are opioid use disorders increasing among older adults? Some of it's just numbers. Our population's getting older. In the 1950s, less than 10% of the country was older than 65. That share will more than double to 23% by 2060. And many of those individuals will have had experience using prescription opioids and illicit opioids. So their opioid use, and potentially their opioid use disorder, will have begun when they were younger. If they survive to 50, they're going to be faced then with the dual challenges of aging and addiction. And in addition to that, in addition just to numbers, many older adults experience pain as they age. Getting older just hurts. And as an aside, dually eligible older adults also tend to have lower levels of family support and financial resources in comparison to beneficiaries covered by Medicare only, making the range of options available for pain management likely more limited. Next slide. So to get more specific about pain, 60 to 75% of older adults suffer from a chronic pain disorder, and the incidence of chronic pain increases with age. This is likely one of the main drivers behind the finding that 1 in 3 recipients of Medicare Part D received a prescription opioid in 2016, with more than 500,000 beneficiaries receiving high dosages, and that average dose far exceeding the manufacturer's recommended amount. So even if a person didn't develop a use disorder as a younger adult, he or she has ample opportunity to develop one later. And of note, dual-eligible beneficiaries have approximately 2 times higher rates of co-occurring substance use disorder and chronic pain relative to beneficiaries with Medicare only, and about 6 times higher rates relative to adults with disabilities who have Medicaid only. So they're particularly at risk. Next slide. So opioid use and opioid use disorder is clearly a problem among older adults. But to be clear, that doesn't mean that no older adult should receive opioids. they should receive them if they're indicated. But the use of opioids, particularly at higher dosages, and particularly over a longer period of time, carries risk. It carries risks inherent in the drugs themselves, so sedation, constipation, falls, overdose. Next slide. And it carries risks in terms of addiction. Medicare beneficiaries have among the highest and fastest growing rates of diagnosed opioid use disorder in the country, at more than 6 of every 1,000 beneficiaries. And from 2005 to 2014, individuals aged 65 and older experienced an increase in inpatient stays related to opioid use. That was an 85% increase. And emergency department visits for related to use, which was 812. And the highest rate of opioid-related inpatient stays was among individuals age 65 and older. Next slide. So opioid use disorder and misuse of opioids among older Americans is clearly a problem, but what do you do? In addition to more judicious prescribing, we need to recognize and treat opioid use disorder when it exists. In the interest of time, I'm going to refer you to the CDC guidelines for prescribing guidance, and I'll focus the rest of my talk on how to know when use becomes disordered and what to do when it's diagnosed. Next slide. So first, let's review how we diagnose substance use disorders. We use the Diagnostic and Statistical Manual, or the DSM. The version now is the DSM V, which provides a standardized way to understand substance use disorders and mental illness. And according to the DSM V, there are 11 criteria that determine whether or not use is disordered. So let's go ahead and review them. Next slide. The first 4 are taking in larger amounts or for longer than intended, unsuccessful efforts to cut down, spending a lot of time obtaining the substance, and craving or strong desire to use the substance. And when I think of these 4, I kind of clump them as the criteria that reflect craving and compulsion. Next slide. The next 5 are recurrent use resulting in a failure to fulfill major role obligations, continued use despite recurring social or interpersonal issues due to use, important activities given up or reduced, recurrent use in physically hazardous situations, and persistent and recurrent physical or psychological difficulties from use. And I think of these as sort of the consequences and loss of control criteria. Next slide. So there are 2 more criteria that only sometimes count, and that's tolerance and withdrawal. So some substances, when they're used appropriately, lead to tolerance, meaning you need more of that substance to achieve the same effect. And if you take it away, a person experiences withdrawal, meaning that they feel sick when the substance is removed. But that doesn't always mean that somebody's addicted to that substance. So if I leave this webinar and I'm hit by a bus and I break a bunch of bones in my body and I'm in the hospital for 2 months getting morphine every day, I'll develop tolerance to that opioid, and I will need more to achieve the same pain control over time. And if I'm discharged from the hospital and I don't have an opioid taper, I'll enter withdrawal. And that doesn't mean I'm addicted to that morphine. That means that my body is dependent on it. Now, if I leave the webinar and I start ordering morphine on the internet for 2 months and I take it every day, I will also develop tolerance to that morphine, and I will also enter withdrawal if I stop taking it. But in that case, because I'm not using it in a prescribed way, those 2 criteria count. Next slide. So knowing the criteria, the 11 criteria, we can diagnose opioid use disorder. A mild disorder is when someone meets 2 to 3 criteria, moderate 4 to 5, and severe is 6 or more. Next slide. Once we have diagnosed, we can treat. Treatment approaches for substance use disorders used to be dominated by abstinence-based approaches, meaning both don't use or drink at all, but also don't take medications that might help you not do those things. However, medications to treat opioid use disorder have repeatedly been shown to decrease substance use, to increase retention and treatment, and to decrease mortality among individuals with opioid use disorder. They're really important to use when indicated. The first that I'm going to talk about is methadone. It comes in a liquid or a pill form, and it's a full agonist at the opioid receptor. And what that means is that it sits on the receptor in the brain and activates it fully, just like morphine or oxycodone or heroin, but it has a very long half-life, so it sticks around at a steady state, and with regular dosing, a patient doesn't get euphoric, but his or her cravings are blocked. Now, it's only possible to prescribe methadone to treat an opioid use disorder from an opioid treatment program, or what people often call a methadone maintenance clinic. So a doctor cannot prescribe it from his or her clinic when it's used to treat addiction. They can use it for pain, but not for addiction. And studies of methadone for opioid use disorder have demonstrated significantly decreased drug use and decreased mortality from opioid use disorder among patients treated with methadone. It also leads to decreases in new infections with HIV, hepatitis, and decreased criminality. Buprenorphine is a partial agonist at the opioid receptor, which means that it occupies that same receptor as the other opioids, but only activates it partially. So patients generally get no euphoria, but their cravings are blocked. This medication can be prescribed from a doctor's office, but prescribers have to obtain what's called a data waiver, which is a special license. To prescribe it, it takes 8 hours of training, and then you can get that license. And they're limited in the number of patients they can treat. So the first year they can treat 30. The second year, if they apply, they can treat 100. And then if they have a few special criteria, after that they can treat 275 patients. This medication also cuts mortality by over half from opioid use disorder. Next slide. So those were the opioid agonists. Extended release naltrexone is another effective tool we use. It was approved in 2010 for opioid use disorder. It blocks opioid receptors. So in this cartoon, the red is the naltrexone blocking the receptor, and the light green are opioids trying unsuccessfully to kind of land on that receptor. It's an injection. It lasts a month, and it has demonstrated efficacy in reducing return to illicit opioid use, increasing treatment retention, and reducing opioid craving. I'm not advancing on my screen. I'm going to assume that it's advancing. Okay, great. There it is. The last medication I want to talk about is naloxone. This is a medication that reverses overdose. It comes in multiple forms, as you can see on the screen. Wally and colleagues in Massachusetts demonstrated that communities that have naloxone distribution from multiple different types of sites have significantly decreased overdose rates. And Coffin and colleagues demonstrated that when providers in primary care clinics in San Francisco prescribed naloxone along with their opioid prescriptions, their patients on long-term opioids had 46% fewer opioid-related ER visits per month in the first 6 months after receipt of the prescription, and 63% fewer after 1 year when compared with patients who did not receive naloxone. It is an incredibly important life-saving medication. Next slide. So let's put this all together with a case study. Diana was a 65-year-old female who was taking about 20 hydrocodone tablets a day, which she obtained from multiple providers and ERs when I met her. She stated that she started using pills about 15 years prior to meeting me after she broke her leg skiing. She found that the pills not only helped her acute leg pain, but they also eased some chronic shoulder pain and, surprisingly to her, eased her anxiety related to her work and her marriage as well. She told me that when she started using the pills, she took about 5 a day, but that she was taking more now to achieve the same effect, bringing her up to the 20 a day. She also told me that she had tried to cut down about 2 years prior because she was getting tired of the effort around having to get the pills, but as she tapered, she felt really sick. She had some diarrhea, she was anxious, she was restless, so she started increasing again. She told me that her husband hates it when she takes the pills because he kind of spaces out. and that he'd be angry if he knew how many pills she was actually taking. So her primary care physician discovered these multiple prescriptions, alerted the other providers, and sent her for an evaluation with me, and that's how I met her. On my exam, she met the criteria for a severe opioid use disorder. She'd been unable to quit down. She'd spent a lot of time obtaining the opioid. She craved it. She had a strong desire. She used to talk about how she would beg for pills from her providers. She continued to use despite social and interpersonal problems with her husband. She had tolerance, and she experienced withdrawal. We started her on buprenorphine, which alleviated her cravings, and it also helped her shoulder pain. She was not interested in treatment for substance use disorder, sort of a formal treatment, but she was open to individual and marriage counseling that touched on that use disorder and touched on some of the other stressors that contributed to her desire to use. And she's been attending those sessions regularly. She also got an naloxone kit. Next slide. So just quick summary. Opioid use disorder affects older adults. The issue is growing, and it's deadly. We diagnose substance use disorders using the DSM V criteria, and we have medications that treat opioid use disorder, and they're life-saving, and we should need to use them. Thank you. And I will turn it over to the next speaker.
Thank you. This is Ann Gazzoni. I am a program manager for physical health and behavioral health integration with UPMC Health Plan. Thank you all for joining today. From the little survey you did at the beginning, it sounds like many of you are social workers and work in managed care. So I think the presentation today hopefully will be helpful in the work that you do. Next slide. So I want to talk about substance abuse in older adults and also family factors. It's very important to understand the family dynamics of substance use disorder. If that's something you've never had training on, I would highly encourage you to learn about the family dynamics of how substance use relates to a family. There's a lot of negative stigma out there and is a barrier to getting help for older adults. And it's also important to know, how does the family view substance use? For example, if they view it as a medical condition versus if they view it as a bad moral character or they're just not trying hard enough, there's going to be maybe a little bit more resistance to getting help. There's a lot of loss and grief and denial associated with substance use disorder. And if you combine this with older adults, the loss of independence, also with losing friends, also if they've experienced any trauma in their life, things like that, it's very important to understand the family situation in which they live. Also, substance abuse can be generational. It can be with their children, maybe even in the family that they grew up in. We see older adults taking care of their grandchildren because their children are now possibly had a fatal overdose. So there's a lot of stress on older adults, and very important to understand the family factors of that. For the loved ones of the person with a substance use disorder, looking at mutual support programs for them. Al-Anon, Nar-Anon, there's many out there in the community, maybe where you live, that are helpful supports and can be very educational about why their loved one continues to use. Or if they're trying to seek help, how just stopping use doesn't make everything better. So these educational programs and mutual support programs are very helpful for family members of the person trying to seek help. Next slide. So there are two types of onset that are important as well. There's early onset of substance use concerns that are before the age of 65, and late onset of substance use concerns, which would be 65 or more. And with Early onset, you're looking at a higher incidence of physical and psychiatric concerns. Maybe they've burned a lot of bridges, so there's not a lot of supports. Their substance use is long-term. Maybe they've had periods of where they were abstinent, but you can see many relapses. You also see with early onset many attempts at treatment. Versus later onset, it might have been something that was related to a medical condition that they received opioids or started combining with drinking, things like that. They might still have some supports. It might be related more to stress or grief, loss of independence, and maybe they've never tried drug treatment before. So that might be just some educational piece for them. Next slide. We're going to talk about Fred a little bit. And Fred is dually eligible. He has Medicare and Medicaid, and he is 66-year-old white male. And he has an early onset of substance use disorder. And the reason why I picked early onset versus the late for my case example is because my guess is that similar to my work, someone like Fred takes up possibly a large portion of your caseload, where he has multiple issues going on at the same time. Might even be sort of this chaotic situation. Multiple risk factors going on, and someone like Fred may take up your whole day, someone you're trying to help. So Fred has visited the emergency room several times for drug overdoses over the past 6 months. He was recently admitted for an infected abscess, and he admitted that this was an injection site of IV heroin. He has chronic medical conditions, including hepatitis C, CHF, and COPD. I just wanted to highlight the hepatitis C because many of our baby boomers have hepatitis C and they don't know it. So this is a very important thing to screen for, is hepatitis C, because as we know now there is a cure for hepatitis C. Next slide. So with Fred, some of his psychosocial situation is that he receives Social Security and food stamps. He is dually eligible for Medicare and Medicaid. And he says that he has a brother, but only call him in case of an emergency. Doesn't sound like a great support. He also has an ex-wife, and you can leave a message there if you need to reach him. So not a great support there either. For transportation, this is a very important thing to assess. And he either walks or takes the bus, so not very reliable transportation. For food, he goes to either a soup kitchen or he uses food assistance. Housing is a huge issue for someone that has a lot going on. He is technically homeless, but he says he can stay with friends occasionally, and his ex-wife will sometimes let him stay there if it's really cold outside. And he uses her address for his mail. And this is an important aspect because getting to know Fred, I learned that, yes, he has an address, but it's not where he lives on a regular basis. He really has nowhere that he lives on a regular basis. So it's important to assess all of these things and ask Fred about his housing. Yes, he might have an address, but he doesn't really live there. So that's a risk factor for him. Next slide. As we're assessing someone like Fred, some tools to use are the NIDA, which is a nice quick, there's a quick screen, and then there's the modified assist to assess, what his substance abuse is. There's also the ASAM, which it helps for placement criteria of what level of care someone could be in. Also, additional assessments could be for social supports, housing, finances, transportation. So a lot of these are psychosocial factors, population health factors that are very important to get the full picture of what's going on in Fred's life. Next slide. What kind of interventions are going to work with someone like Fred with a very chaotic situation, lots going on? It's very important that it's person-centered. What's going to work with Fred may not work with someone else. And also, when he's ready to take action, when he says, I really need some help, I can't live like this anymore, and taking those rapid interventions so that he can really gain help when he's ready. Motivational interviewing techniques are very effective at assessing a person's readiness to change. Getting educated on motivational interviewing can be extremely helpful. Also, again, assessing the family involvement. Having his family involved can be a protective factor. For example, if maybe there's new grandchildren in Fred's life, that might be something that might be a motivator for him to change, to start taking some steps in more healthy behaviors. Once someone like Fred is ready and says, I think I'm ready, I need some help, having a face-to-face intervention is really helpful. Know that the resources in your area as clinicians, as helpers, who can get face-to-face? When is the next time Fred's going to be going to the doctors? Does he have a way to get there? Is there someone that you can mobilize to go and meet Fred where he is? Is there a home health that would be willing to go and see him? I've had home health agencies that were willing to go to a homeless shelter to see someone. So knowing which is the best face-to-face help. We also have community paramedics that are very helpful in our area in Pennsylvania, and they may have a similar program where you are. Peer recovery specialists are such a wonderful asset in recovery. They have lived experience in recovery. They can get a special certification. There's a certified peer recovery specialist training that they can complete, and they can really meet that person where they are and say, I understand what you're going through. I've been there. And that is very effective in engaging someone in treatment and also maintaining them in treatment. Next slide. Having expert staff is very important in care coordination. The care team and the components of that care team are very important, that they are skilled in many areas. Many people access a medical, clinical situation for substance abuse. So do those medical staff have training in substance abuse? Is there someone on staff who has that ability to assess and care for them, whether it be in a primary care office, whether it be in an emergency room? Many of you work for managed care organizations on this call today, and we can see lots of utilization, which can be really helpful to pass along to anyone who might help that person. Staff who can facilitate admissions to detox and rehabs and not just give phone numbers. If you give someone who is still using a phone number and say, here's a phone number to medication-assisted therapy, here's a phone number to treatment, that's good, but often making that phone call with them is much more effective. The chances of them following up might be slim. And when you think about your own organizations, how are you hiring? Hire that staff person that has lots of experience in lots of different areas to help them remove barriers. We don't want to transfer people, like I said, just give phone numbers. We need those staff people, those clinicians, the peer navigators, the peer recovery specialists, really to have at the fingertips the resources that are needed. For example, Fred has a mobile case manager, and that person can go right to wherever Fred is and connect him with services, substance abuse services, either inpatient or outpatient, and also medication-assisted therapy. Next slide. Some treatment resources, again, having staff with the knowledge of the criteria for different treatment options, what's in your specific area, what medication addiction treatment is out there. There's also a mobile app through SAMHSA that's really helpful. And Dr. Gregg also talked about Narcan and naloxone to treat overdoses. This is very important. Hopefully first responders have these things. There's a way also to get them for free at different places in your community. And we need to have a person-centered recovery process so that to engage that person. Maybe they're not ready for treatment, but maybe they will help you with the fact they're going to be evicted. And so you're keeping that person engaged with helpers, you're keeping that person talking with you, and that in itself can be a success so that eventually a trusting relationship can be formed. Mutual support programs, again, we talked about Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, Nar-Anon for family members of that person seeking treatment. Next slide. This is the Surgeon General's advisory on naloxone and opioid overdose, so you can read that. It's very important to use naloxone. It can save a life. Be prepared, get naloxone, and save a life. Next slide, please. So we have our next presenter is a consumer, and I'll pass it along to Carol.
Hello. My name is Carol. I'm a recovering alcoholic, and I'm from Onset, Rhode Island. Thank you for inviting me today to briefly share my story with you. I got into recovery after many years because basically I had lost everything I had and lost myself along the way. Whenever I had even $2.50 in my pocket, I would get a drink, not food. And if I didn't have the money, I'd find a way to get it. I'd panhandle, do anything to make the $2.50. I was canning, and I got my money to cash for alcohol. One day I was hitting up a house. A police officer pulled up in his cruiser, and he ticketed me. I was still drinking pretty heavily, and when I went to court, they wanted $125, and I just did not have it. So I went to jail. A good thing, because I could have a warm bed and 3 meals a day. When I got out of jail, I went back to living under the railroad tracks. For food, I'd go through the dumpsters at Kentucky Fried Chicken. Sometimes the workers at a nearby Chinese restaurant helped me with food. Living on the street was hard during the winter, and I came down with frostbite. The old folks who lived across the street from me hadn't seen me all day, so they came over and saw I was in a tent and that I couldn't move, I couldn't walk. So they called rescue and got me to the hospital, and first thing they thought I was numb and drunk, and they put me in a drunk ward. They took blood, and they saw I was sober, and they admitted me for 7 days. Really, for me, it was like being at a 4-star hotel. When I left, the nurses knew me, and they sent me home with clothes and Dunkin' Donuts cards and cigarettes. I started going to a program in Woonsocket where they had doctor's services, and a lot of folks hung around there to talk and stay inside where it was warm. Every Friday we got together to talk. Started with 5 and grew to 30. A lot of people were trying to stay sober. Then I met Diego, my peer recovery specialist, through someone else at the family shelter, and he got me into a detox program at a local hospital. Once I got over the withdrawals, I went to live at Amos House and started really working the program. Diego checked in on me every week, would bring me things, take me to my medical appointments, and help me get on disability. I have coverage through the neighborhood health plan, and they have been really helpful. I didn't realize how sick I was, but they have taken care of me from getting my inhalers to my can't say the word, but my breathing nebulizer machine, and even my eye doctor. I also get Richter bus tickets that help me get to my recovery groups. I am now in phase 2 of my program. I'm in independent living, my own room, my own bathroom, and I have a caseworker. What I would like to tell all of you who are trying to help people like me is what I needed. I needed someone to be my advocate, and that was Diego. I needed housing, so I had a place to go after detox, not back to the streets. I needed medication that I could afford, like my insulin, and I needed help with transportation, which I did get through the help of the advocates and through the program I'm in now, which has been very helpful. I got to say a lot for the Amos House and the programs that have gotten me where I am today. Without these programs, there'd be a lot more deaths in this world. Thanks for listening, and I hope my story will help others.
Well, Carol, thank you so much for sharing your story with everyone today.
You're welcome.
Thanks so much. Thank you. And thanks so much to our speakers, Dr. Oslin, Dr. Gregg, and Anne as well. This has been really incredibly informative, and thanks for joining us today.
Okay, thank you.
So with that, we actually now have a few minutes for questions from the audience. At this time, if you have any questions for our speakers, please submit them using the Q&A feature on the lower left of the presentation. Type your comment at the bottom of the Q&A box and then press Submit to send it. So we've had a couple questions come in throughout the presentation. And Dr. Oslin, I'm going to start with a question that came in earlier in your presentation. And the question is just, I know you touched on this briefly, but can you elaborate a little bit more on what you mean by generativity?
Yeah, it's a term from Erickson's developmental stages of life, and it roughly translates into purpose. So the notion that I feel like I know why I'm living and know what I'm doing and what role I'm playing in my stage in life. So, you know, we as working adults, our purpose often is our existing families and our work. And as we get older, you know, those things, we retire and we subside. And some people are very good at picking up hobbies or having grandkids, which is also a hobby. But some people really struggle with this, and it's part of what leads to suicidal thoughts, but it's also part of the loss that can lead to increase in substance use. So hopefully that helps. It's a nice way of, if you want to go back and read some Erickson, it's a nice way of conceptualizing some of the psychodynamic issues that affect us as we age.
Great, thank you for that added context. Dr. Gregg, I'll turn to you next for a question that came in during your presentation. The question is, many older adults have chronic pain and need opioids, but do not misuse the opioids. How can you tell when a patient will misuse the opioids? Is it the length of time they are on one or the type of opioid specifically?
That is a great question. So there are a couple things. One, we do have risk tools before starting someone on an opioid, and that doesn't, and if somebody scores high on a risk tool, a risk of opioid use disorder or opioid misuse, that doesn't mean that you don't necessarily prescribe the opioids, but you might be more vigilant about the rapidity of the taper and making sure that it's being taken as prescribed. But that's a different scenario than having a patient who has been on opioids for a long period of time, and now we're becoming much more vigilant and much more aware of the extent of opioid use disorder and the deadliness, how dangerous it is to our patients. So I think people are really struggling with this because on the one hand, in good faith, they prescribed to patients in pain, and in good faith, those patients took opioids and are still on them. And now we're recognizing the downside. So my approach is generally, if somebody has been on opioids for a long period of time and they've been taking them as prescribed and they haven't suffered real consequences from that use, and those consequences can be, things as varied as decreased bone density, increased depression, increased fatigue. A lot of times we put patients on opioids and we're not paying attention to all the side effects. But let's say that we have a patient who has had minimal side effects, is taking them as prescribed, and has been on them for a long period of time. I don't take those patients off of their opioids just because we're now much more aware of the dangers. I will often, if they're on higher dosages, above 90 morphine equivalents, say, let's get you down to what we consider a safer dose, because the risk of overdose and the risk of other consequences is lower on lower doses. It's the importance of primary care and long-term relationships to do that. Those are the contexts in which those tapers or non-tapers or assessments of opioid use are best done.
Great. Thank you, Dr. Gregg.
This is Dr. Osmond. Can I just add that the other thing to emphasize is the concurrent use of alcohol or benzodiazepines, which also markedly raises people's risk for death at even lower doses.
Okay, thank you, Dr. Osmond. Great. Anne, I have a question that came in during your presentation, and I think you touched on this a little bit during your case study with Fred, but perhaps you could go into a little bit more detail. So the question is that you talked about the importance of supporting members with social supports, and then the importance of having an interdisciplinary care team and having family support as well. So what do you do for older adults who live alone and may not have family or a support system?
That's a really good question. I think that many older adults do live alone, and assessing what is out there for them that they could qualify for. For example, our dually enrolled members may have an eligibility for long-term support services, which is a caregiver in their home. So are there things that they could be getting support in their home so they can maintain their independence in their own home, which is where a lot of people want to be maintained, not living in a nursing facility. So knowing what the person is eligible for to gain social supports when they do not have family, and also possibly what mobile mental health or substance abuse treatment could be obtained in their home. And again, having that knowledge of what's available to them, what do they qualify for, having that expertise is very important.
Thank you, Anne. Dr. Osmond, I'll turn back to you, and this came up during your portion of the presentation when you talked about the different servings of alcohol. So the question is that the information you provided asks about 6 or more drinks, but binge drinking definition looks like 4 or more. And this individual is also seeing the number 5 for the number of drinks. So he wants to know if there's a current standard definition used across healthcare settings for binge drinking.
Yeah, it's a great question, and actually there's a superb article that just came out in Lancet on drinking that questions a lot of this as well. So I think my slide should have said more than 4, which would be the same as 5 or more. So first you have to look at that, so I think you will see a little bit of confusion between some different things. For us in research, we use 5 or more, which is greater than 4 as the standard. The Lancet article I just referenced actually raises questions about whether drinking over 1 standard drink per day doesn't increase your risk, and that they did not find a gender difference and they didn't find an age difference. So the risk for lots of negative things started at 1 and then rose exponentially as you increased, which is a little bit different than what the U.S. is actually recommending right now. That Lancet article was a compilation of a lot of European data. But it's a great question. The reality is you're trying to get at heavy drinking in a day. And the other piece, the other things that I would say about this to trainees is that none of us carry an I&O sheet around in our pocket, so we don't really monitor how much we drink. Often people know how much they buy, but the notion that people keep track of ounces is a little bit crazy. If I were to ask any of you guys to kind of tell me how much coffee you've had each day over the last 2 to 3 weeks, you'd soon see how hard that is to do. So we're just trying to get really close to the truth and not, as in that slide showed, not a very large drink when it really is not what they're talking about. We're trying to have a common language here with our patient.
Great, thanks, Dr. Oslin. And this isn't a question, but Carol, I just wanted to let you know that we have a lot of comments coming in through the Q&A, just thanking you for sharing your story and congratulating you on your success. So I wanted to share that with you.
Thank you.
Okay. And this question probably can go to you. The question is if you could recommend resources to use for accessing readiness of change or motivational interview techniques.
I would. There's so much help out there, but it's not very well put out there in the right way. It scares a lot of people. They think that going to a detox and everything's going to be done, and they're going to go right back out there and everything's going to be easy. There's a lot of homeless people. Like I said, I lived in a cave. I've been out there, and like I said, and the thing is you got to have, I think, more outreach people out there to help these people. People out there and seeing it themselves, talking about it doesn't really see it with the eyes, And now that when I go back to my Woonsocket, Rhode Island, go there, my doctors and stuff, and I see it continuing, But when they see somebody like me and how far I've gotten, they're willing to try it, again. But that one that makes it is what counts. If it's just one that can make it, and then that one goes and the word keeps going, And you go to groups and you end up in meetings and you see people there, AA meetings, any type, group meetings. They come out. I can't say more about the meetings, and not to be afraid to talk to your physicians. They eventually, you're going to have them that have doubts, but it's because of your past. And you can't blame the physicians for that. You can't blame the psychiatrists, It's just like me going for my disability because of my alcoholism. They're throwing all that in my face. Well, I'm sober now, so why are you putting my past to me again? I've been doing great. I am doing great, and I plan on doing great. I don't look back. I live for the present and hope for the future. That's what I do. So with that, have a good day, everybody.
Thank you, Carol. Really appreciate you sharing your perspective. And if you're still on, I don't know if you could comment a bit more on this question, specifically any resources that you might recommend for assessing readiness of change and motivational interview techniques.
Sure, and I just want to thank Carol for her comments. I think she's very inspirational and kind of fits in with the motivational interviewing. SAMHSA has some nice information about motivational interviewing on their website. There's many trainings out there that you could search for in your local areas. Where I am employed, we have motivational interviewing as part of all of our onboarding of our new employees. But SAMHSA would definitely be a great place to start. We're learning about motivational interviewing and readiness for change. And along with what Carol was saying, there's recovery is a process, and that motivation waxes and wanes. Having those support people who are skilled in motivational interviewing along the way, whether it be peer recovery specialists, social workers, even PCPs, to keep that person engaged in their recovery is so important to continue the motivation to change, because some days are harder than others, and we all need a cheerleader sometimes. So And motivational interviewing has a great structure for that. Thank you.
Great, thank you, Anne. And we have a number of questions coming in, so we really appreciate the audience staying engaged and reaching out with your questions. For the questions that we can't get to today, I just want to let everyone know that we'll work on creating a question and answer document, and we'll be posting that to our website. So I think we have time for about one or two more questions. And for this question in particular, I'll open it up to everyone on the panel today. The question is, what is the relationship of adults' right to self-determination and their willingness or unwillingness to participate in substance use disorder treatment or care programs? They cannot be forced to participate, so how does one help individuals that no one knows are at high risk for abuse, neglect, or substance use disorder?
This is Anne. From a clinician perspective, a case management perspective, they do have that right to self-determination, and having that person at the center of their treatment is so important. And understanding the recovery model and that recovery is a process, having that person engage with a helper is a success right there. Maybe they're not ready to stop their use or decrease their use, but they would like help with something else. They don't have enough to eat, or their medical equipment broke and they need a new walker, or whatever it is that they need, and they're willing to continue that relationship. I think that's that they're kind of leading the way, and developing that trusting relationship is important for self-determination. I think Dr. Oslin mentioned that people have to be ready to change. It can't be forced. And, having that relationship with that person is very important. Along the way, what do they want help with right now? And taking that lead from them.
This is Jessica Gregg. I would echo that. With a specific example, I had a patient who did not want to stop using heroin, but actually was interested in some help with smoking cessation. So we started with that and really didn't talk about heroin. But once he actually cut down on his smoking, he kind of thought about other things that he might want to change. And eventually we did get him onto buprenorphine, and he isn't using heroin. But that was of absolutely no interest to him when I first saw him. And I would also echo something that she said earlier about the peers. We have a peer on our team, and so having a peer also not pushing that agenda, but able to support that patient in his smoking cessation first and in sort of talking about his other goals was unbelievably important.
Great. Thank you both for sharing. I'll go ahead with one final question before we conclude for today. And Dr. Gregg, this might be a question for you, but of course others, please feel free to jump in. The question is, how should we initiate a conversation with a pain management physician who is prescribing a high dose of opioid for many years to a family member and suggest how this physician can reduce the opioid?
I want to make sure I understand the question. So it's a family member wanting to talk to a pain physician?
Yeah, I think that's what this
provider.
question is getting at.
I
was going to say maybe the family member having the conversation with the provider.
I mean, first, it's important to talk to the patient, him or herself, because they have a right to know, I think, what's being said about them to their provider, and to be able to say, I don't want, to say to the provider, I don't want you to talk, or it's okay. I mean, that's their right. So I think that's first and foremost what has to be dealt with. And then if the patient is comfortable, then I think expressing a valid concern over a dosage and saying, can we open that dialogue with the patient as well, though. It can't be a runaround. You know, it doesn't happen through a back door.
All right. Okay, great. Thank you, Dr. Gregg. So at this time, if you have any additional questions or comments, please email us at ric@lewin.com. And for more information, you can also find a list of resources related to supporting older adults with substance use disorder in the last few slides of this presentation. Before we conclude, we also would like to take a few minutes to hear more from the audience. And so we'd like to know, within your particular discipline, what else would you like to learn about substance use disorders? So we'll give everyone just a couple of minutes here to enter your response using the Q&A feature. All right, great. Thank you, everyone, for sharing. We'll definitely take this into consideration for any potential future work. So we'd also like to invite everyone to visit our website to view recordings of our webinars that aired earlier this year. So these webinars include Safe and Effective Use of Medications in Older Adults, Disability Competent Care 2018 webinar series, and Providing Culturally Competent Care, Meeting the LTSS Needs of Dually Eligible Beneficiaries. The slides for today's presentation, a recording, and a transcript will be available on the Resources for Integrated Care website shortly. At this time, the post-tests for this webinar are now open. Additional guidance about obtaining credits and accessing the links to the post-test can be found within the Continuing Education Credit Guide in the Resource Guide on the left-hand side of your screen, or at the Resources for Integrated Care website. Thanks so much for joining us today. Please complete our brief evaluation of our webinar so that we can contribute to delivering high-quality presentations. If you have any questions for us, please email us at ric@lewin.com. Thanks again to all the speakers. Have a wonderful afternoon, and thank you so much for your participation.